So in this video, we'll talk about some physical exam findings we see in rheumatologic patients. Now, this is supposed to help you when you see the patients in practice, as well as when you study for your exam. It helps you understand when we talk about these findings in rheumatologic diseases and what do they mean. If the patient has a swelling and tenderness in one of the joints, then it means that there's an inflammatory process. What if the patient has inflammation in the insertion site or in the whole finger? So in the insertion site of the tendon we're talking about, we call it enthesitis. And if the whole finger is involved, we call it dactylitis. And both of these are seen in reactive arthritis and psoriatic arthritis. Now, what if they give you the description of the skin that has thickness in the hands mainly? This we call sclerodactyly. If they describe you a whitish spots that are painful on the tips of the fingers, then we call these calcinosis. And both are seen in scleroderma. Yeah, so again, try to understand how these descriptions are given and imagine them or see some pictures of these patients. This will help you in the practice as well as in the exam. Now, moving on, we can talk about Raynaud's. First of all, you need to understand the description again. The patient will come and tell you, well, I have this pain in my hands, both of them, and sometimes I feel they turn in color from white to blue, then back to red. So you have to think, well, this patient might have Raynaud's. Now, the next question will be, is this primary or secondary? And things that can help you differentiate, you need to ask the patient if they have any ulcers in the tip of the fingers, or if they're taking some medications that can increase the risk of Raynaud's, or if they have symptoms of SLE, which is associated with the Raynaud's phenomena, as well as if they smoke or take any nicotine in any other formulations. And it's important to note that ulcers by themselves, when they are present with Raynaud's, it gives you a big hint that there is a secondary cause for this Raynaud's phenomenon, because primary Raynaud's does not usually present with ulcers. Another important hint is the age. Whenever you see the age less than 30, then you might consider primary Raynaud's. Otherwise, if the patient is above 30, this is unusual for primary Raynaud's to present at that time. Now, why we need to know what caused the Raynaud's? And the answer, because the treatment can be different. So if we have secondary cause, then we need to treat the cause. We can as well add calcium channel blockers. And most importantly to know is aspirin can be helpful, especially as we mentioned that secondary Raynaud's can present with ulceration and ischemia, and aspirin should help. Now, for primary, we treat them usually conservatively. Ask the patient to keep their hand warm, whether with wearing gloves and avoiding cold surfaces. Next, we'll talk about purpura. First of all, we need to differentiate it from petechia. Petechia are usually less than ½ centimeter, whereas purpura is from ½ centimeter to 1 centimeter in size. Now, it's divided into two main categories based on the examination: non-palpable and palpable. So when we are talking about non-palpable, it means that there is some leakage in the vessels. And this leakage means that there is low platelet count. And that can be seen in ITP, TTP, DIC, and any other cause of low platelets. While in palpable purpura, there is redness in addition to some thickening and raised skin. It means there is something happening underneath the skin, which mainly means vessel thickening secondary to inflammation, i.e. vasculitis, with examples including cryoglobulinemia vasculitis such as P, polyarteritis nodosa, microscopic polyangiitis, etc. And this concludes this video. Hope you guys learned something. See you in the next one.